Um, Welcome to this revision deep dive. Let's just skip the fluff and jump straight into the material today.
Right, absolutely. We are two plastic surgeons, and our premise today is strictly business. We are breaking down high-yield, board-relevant topics for residents preparing for exams.
Like the FRCS.
Exactly. Today's mission is a comprehensive question and explanation breakdown on breast and nipple reconstruction.
We're stripping away the noise, giving you exactly what you need to know to confidently ace your exams.
And before we dive in, press follow on the show right now.
Yeah, leave a rating if you learned something today and drop a comment with the topics you want us to cover in future deep dives.
Also, you really need to grab a premium subscription today to unlock our highly requested Journal Club and Clinical Cases deep dives.
You definitely do not want to sit for your boards without having mastered those. So let's jump straight into the first exam topic.
Let's do it.
So, starting off with timing and oncoplastic principles. How do we classify the timing of reconstruction, and what is the specific algorithmic approach for that delayed immediate reconstruction?
Well, when we look at breast reconstruction from an examiner's perspective, establishing the foundational principles and the timing is, well, it's the ultimate starting point.
Right. If you don't have the algorithm locked in, the specific surgical techniques won't even matter.
Exactly. So we classify the timing of reconstruction into three main categories. First, immediate, which obviously occurs during the same operation as the oncological clearance.
Then delayed, which happens months or years later.
And finally, the heavily tested hybrid concept, the delayed immediate reconstruction.
Yeah, the delayed immediate pathway is one of those highly testable concepts because it requires you to understand the multidisciplinary nature of breast cancer treatment.
It does. You are essentially creating a holding pattern to preserve the skin envelope.
You insert a tissue expander at the time of the mastectomy while you wait for the final pathology.
And the definitive adjuvant radiotherapy decisions. You're building a fork in the road for the patient's reconstructive journey.
So let's talk about that fork. If that final pathology dictates that no radiotherapy is required, the path forward is pretty straightforward.
Very straightforward. You take the patient back to the operating room in the ensuing weeks, remove the expander, and perform the definitive reconstruction.
Utilizing that beautifully preserved native skin envelope.
Right. However, if the medical oncologists determine that radiotherapy is required, you leave that expander in place.
You delay the definitive autologous tissue reconstruction until a later date.
A much later date, well after the radiation treatments are complete and the tissues have had time to recover.
Because that protects your definitive flap from the devastating fibrotic effects of the radiation.
100%.
Okay, moving from the timing of total reconstruction to partial breast reconstruction after breast-conserving surgery. The examiners will expect you to fluently categorize the actual tissue movement.
Yeah, you must distinguish between volume replacement and volume displacement.
Volume replacement is exactly what it sounds like. You're transferring new distant tissue into the breast defect to replace what was lost.
Whereas volume displacement means you are strictly rearranging the existing local breast tissue to fill that oncological void.
And for the boards, Clough's classification is the gold standard here.
It is. It categorizes these oncoplastic displacement techniques based on the sheer percentage of volume lost. The examiners love Clough's classification because it dictates your surgical limits.
So let's break that down. Level I applies when there is a relatively small loss, 20% or less of the total breast volume.
The reconstruction here relies on a dual-plane undermining of the glandular tissue. You separate it from both the skin and the pectoralis fascia.
Followed by glandular reapproximation to close the dead space.
And the keyboard facts to anchor in your mind for level I, no skin excision is required.
Right, and if the nipple areola complex, the NAC, needs repositioning,
you simply deepithelialize a crescent of skin adjacent to the areola and advance the complex.
Now, level 2 is where the surgical complexity scales up significantly.
Yeah, this applies to a volume loss of 20 to 50%. You can't simply pull the remaining gland together without causing a severe visible deformity.
So this requires therapeutic mammoplasty.
Exactly. You're utilizing classic breast reduction techniques, which inherently involves strategic skin excision, glandular rearrangement, and total breast reshaping.
A classic trap the examiner might set here is asking about tumors located outside the normal excision zones for a standard wise pattern reduction.
Oh, they love that one. For those outlying defects, you have to design secondary parenchymal pedicles.
Or creatively extend the primary pedicle to rotate tissue into the defect.
Right. And central defects also require specific, testable solutions. For those tricky periareolar or retroareolar tumors, local flap options are your go-to answers.
Like the gratuity flap. It's a rotational advancement flap that brings inferior tissue up to replace the areola.
The batwing or omega flap is another classic. Think of the batwing flap literally like the emblem on Batman's chest.
It allows you to centralize the nipple while hiding the scars in those upper and lower crescent borders.
They are perfect tools for volume displacement in those central zones.
Let's shift our focus to segment 2, alloplastic options, specifically breaking down implants, expanders, and a cellular dermal matrix.
Because not every patient wants or is a candidate for autologous tissue.
Exactly. So for implant-based reconstruction, what are the ideal patient criteria?
The ideal candidate generally has a smaller breast size, typically an A or B cup, and they absolutely must have healthy, non-irradiated overlying skin.
Traditionally, we aim to place these implants under the pectoralis major. But what are the specific anatomical limitations of subpectoral placement after a mastectomy?
You need to be able to list these rapidly for the examiner. The primary limitation is poor control of the lower pole of the pocket during the expansion phase,
Which often leads to a high-riding implant.
Secondly, you're dealing with unprotected coverage by a very thin inferior mastectomy flap.
That increases the risk of implant extrusion or rippling.
Third, the dissection often leads to the effacement or wiping out of the inframammary fold, the IMF.
Which is the foundational landmark of the breast.
And finally, there's the phenomenon of window shading, which is the limited control over the superior migration of the pectoralis major muscle itself as it contracts.
So before we discuss how to solve those lower pole issues with ADM, you need to know the specific mechanics of the tissue expanders used in these pockets.
Let's compare the ones you need to know.
What differentiates the Mentor Siltex Becker from the Nitrile Style 133V?
Take the Mentor Siltex Becker expander first. It's essentially a 2-in-1 dual-lumen device. You have an outer shell filled with fixed silicone gel, which accounts for 25, 35, or 50% of the final volume.
Depending on the specific model.
Right. But the inner lumen is an empty saline pocket. You expand that inner pocket percutaneously over time through a remote port.
And the brilliant part is that once expansion is complete, you simply pull the remote port out by traction.
A self-sealing valve engages, and your temporary expander has just become your permanent implant.
Now, the Nitrile Style 133V expander takes a completely different engineering approach.
It's a shaped device designed specifically to force more projection into that stubborn inferior pole we just talked about.
Instead of relying on a remote port that requires a separate subcutaneous pocket, the expansion is performed via an integral valve built directly into the anterior shell of the device.
You locate that internal valve blindly from the surface using a sterile magnet to guide your needle.
Both of those devices historically relied on purely muscular coverage. But how does a cellular dermal matrix, or ADM, fit into the reconstruction algorithm?
ADM completely altered the reconstructive algorithm. It allows for total implant coverage and lower pole support without having to elevate adjacent autologous tissues like the serratus anterior or rectus fascia.
It's optimally suited for small to medium-sized breasts. And the highly testable procedure here is the single-stage, direct-to-implant process following a skin-sparing mastectomy.
The surgical steps for that single-stage SSM-ADM process need to be memorized sequentially.
Step 1. Develop your standard subpectoral pocket by elevating the pectoralis major.
Step 2. Suture a sheet of ADM directly to the released inferior border of that pectoralis major muscle.
Step 3. Insert the definitive implant into this newly created combined muscle and ADM pocket.
Step 4. Fashion the inferior border of the ADM around the lower pole of the implant like a hammock.
Step 5. Close the pocket by suturing the inferior edge of the ADM directly to the chest wall fascia.
Which artificially recreates your new inframammary fold.
Finally, Step 6. You must place a surgical drain in the space between the ADM and the overlying mastectomy skin flap.
That drainage step isn't just a precaution, it's a physiological necessity. The ATM is a cellular scaffold that requires vascular ingrowth from the overlying mastectomy flap to integrate successfully.
Any fluid collection, like a hematoma or a seroma, creates a physical barrier that delays or prevents that revascularization.
A non-vascularized piece of biological mesh is essentially a foreign body sitting in a dark, warm pocket.
Which drastically increases your infection risk and the likelihood of losing the entire reconstruction.
Exactly. Now, the data on ADM is compelling, but comes with caveats you must quote to the examiner.
Let's hear the complication rates.
On the positive side, one study of 260 patients demonstrated that ADM reduced capsular contracture rates to an incredibly low 0.4% after a 29-month mean follow-up.
Likely because it acts as a barrier to the inflammatory cascade that causes contracture.
But the complication rates you need to recite are a 5% rate of clinically significant seroma,
A 5% rate of infection.
and a 4% rate of complete reconstructive failure requiring device explantation.
You must also remember that if the oncological resection requires substantial skin excision, or if you evaluate the mastectomy skin flaps and their vascular viability is doubtful, a single-stage procedure is contraindicated.
You must fall back to a two-stage process, inserting a tissue expander first to gently stretch the compromised skin.
Moving to segment 3, the workhorse autologous flaps. When alloplastic options are contraindicated, or the patient prefers their own tissue, we look here. This is the absolute bread and butter of the FRCS exam.
Starting with the back, let's look at the variations of the latissimus dorsi or LD flap. It offers incredible versatility.
First, the LD mini flap, which harvests just a small segment of the muscle to fill quadrantectomy defects.
Then the traditional LD myocutaneous flap, which utilizes crescentic or trefoil-shaped skin paddles to replace the skin envelope.
But the major drawback of the traditional LD is that the back simply doesn't provide enough adipose bulk for a fully autologous reconstruction in a standard-sized breast.
Right, it usually requires an underlying implant. To avoid an implant entirely when using the back, you have to transition to the extended LD or ELD flap.
This involves harvesting a much wider territory of adipose tissue beyond the standard skin paddle.
You incorporate the fat covering the entire muscle surface, extending into the scapular area, anterior to the muscle border, or even sweeping down into the love handle area above the iliac crest for a fully autologous reconstruction.
And for residents aiming for top marks, be prepared to discuss the TDIP flap, the thoracodorsal artery perforator flap.
Described by Engrigiani in 1995, it relies on the vertical intramuscular branch of the thoracodorsal artery,
allowing you to harvest the overlying skin and fat while preserving the latissimus muscle entirely, significantly reducing donor site morbidity.
Now for a major board topic, abdominal flaps. The abdomen remains the gold standard donor site.
Let's break down the tram flap, its vascular supply, and the critical skin paddle zones.
The historically original pedicled tram flap is supplied by the superior epigastric vessels.
You can perform a surgical delay procedure by ligating the deep inferior epigastric vessels a few weeks prior to improve survival, forcing the choke vessels to open.
But the pedicled tram carries high local complication rates compared to the free tram.
Specifically, marginal fat necrosis due to the tenuous blood supply, and a high risk of an unsightly abdominal bulge or hernia.
Especially if both rectus muscles are sacrificed to improve venous drainage, the high morbidity of the pedicled tram drove the evolution to the free tram,
which is based on the dominant deep inferior epigastric artery, or DIEA, and its accompanying veins.
The anatomical branching patterns of the DIEA are a favorite exam question. Remember these percentages.
50% lateral dominant. That is your most common scenario.
The medial and lateral branches are equal in caliber in 15% of cases.
The medial branch is dominant in only 7%.
And finally, a single central axis with multiple smaller side branches is seen in 28% of cases.
Knowing this anatomy dictates exactly where you look for your most robust perforators during the dissection.
And the perfusion of the abdominal skin paddle relies on understanding the 4 zones of perfusion.
Originally described by Hartramp and later modified by Holm, Zone 1 is the tissue directly over the ipsilateral rectus abdominis muscle, receiving direct vertical perforators from the DIEA. It has the most robust blood supply.
Zone 4 is the exact opposite. It lies over the extreme contralateral side of the abdomen, completely outside the DIEA territory,
relying instead on the superficial circumflex iliac artery, or SCIA.
Because the blood has to traverse multiple choke vessel networks to reach Zone 4, it's relatively poorly perfused and is almost uniformly discarded to prevent fat necrosis.
Now, the controversy that examiners love to trap you with involves Zones 2 and 3. Do they cross the midline?
Right. In Hartramp's original anatomical description, based on the pedicled tram, Zone 2 was the contralateral medial segment directly across the midline, and Zone 3 was the ipsilateral lateral segment.
However, Holm later demonstrated using indocyanine green angiography in free flaps that the ipsilateral lateral tissue actually perfuses better than the tissue across the midline.
So Holm redefined zone 2 as the ipsilateral lateral segment and zone 3 as the contralateral medial segment.
Always clarify whether you are referencing Hartranft's anatomical zones or Holm's physiological zones before you start sweating under the examiner's gaze.
Good advice. Now, preserving the abdominal wall function is the driving force behind modern microsurgery. How do we classify muscle sparing or MS tram flaps?
We run through Nahabedian's classification. MS0 involves a full-width, partial-length harvest of the rectus muscle.
MS1 preserves just the lateral segment of the muscle.
MS2 preserves both the lateral and medial segments, harvesting only the central strip containing the perforators.
And finally, MS3 is the true DEP flap, which preserves the entire rectus abdominis muscle.
The DIEP flap uses the exact same abdominal skin paddle as the tram, but you painstakingly dissect the DIEA perforators directly through the muscle fibers,
Crucially, you preserve the intercostal motor nerves traversing horizontally through the muscle.
which significantly decreases donor site weakness and hernia risk.
The trade-off is that it's technically demanding, requiring meticulous intramuscular dissection.
And it carries a higher rate of venous congestion and fat necrosis compared to a free tram if you select inadequate perforators.
We should also briefly define the SIE flap, the superficial inferior epigastric artery flap.
It uses the same skin envelope as the DIEP, but doesn't breach the rectus fascia at all.
Its fatal flaw is a highly variable, often incredibly small diameter artery that makes microvascular anastomosis treacherous.
All right, segment 4, alternative flaps and lipomodeling. If the abdomen and back are unavailable, what are the secondary flap options?
Let's say a patient has had previous massive laparotomies and their latissimus is too thin. We look to the gluteal region.
The SGAP, based on the superior gluteal artery, and the IGAP, based on the inferior gluteal artery.
The IGIP is frequently favored purely for aesthetic reasons, as it offers superior scar concealment directly within the natural buttock crease.
You also need to mention the new DFAPAL, or deep femoral artery perforator flap.
Utilizing tissue from the posterior thigh and lower gluteal fold, offering a longer pedicle than the traditional gluteal flaps.
Looking at the flank, the Rubens flap is a viable, though less common, option.
Based on the deep circumflex iliac vessels, it harvests the robust soft tissue overlying the iliac crest.
That prominent, localized fat pad, famously depicted in paintings by Peter Paul Rubens.
And if we look to the lower limb, the 2U glap, or transverse upper gracilis, is highly testable.
It harvests the gracilis muscle along with a transverse paddle of skin and fat from the upper medial thigh.
The tissue volume is relatively small, so it's strictly reserved for small breast reconstructions or filling partial oncological defects.
Now, all of these techniques often require a secondary touch-up, which brings us to lipomodeling, or autologous fat transfer. What are the indications and specific drawbacks?
You'll use lipomodeling constantly. For correcting contour defects after breast-conserving surgery, adding soft tissue camouflage over visible rippling in implant reconstructions,
Providing volume augmentation in autologous flaps that have atrophied.
and crucially, stimulating neovascularization in chronically ischemic irradiated tissue.
The adipose tissue brings in a rich supply of angiogenic factors that actually reverse some of the radiation damage.
Despite its utility, lipomodeling has significant drawbacks. The primary issue is incomplete fat survival, or take.
A significant percentage of the injected fat will resorb, meaning patients must be counseled that repeat stage procedures are the norm, not the exception.
The dead fat leads to fat necrosis, microcalcifications, and macro oil cysts.
This is a massive clinical issue because these benign calcifications mimic the radiological appearance of breast cancer.
Leading to immense patient anxiety, unnecessary imaging, and highly stressful core biopsies simply to rule out a local recurrence.
And that fear of recurrence leads to a crucial board exam trap regarding stem cells.
Because lipomodeling involves transferring adipose-derived stem cells into a bed that previously housed a malignancy, there is theoretical concern that these stem cells could stimulate dormant cancer cells.
If the examiner presses you on this, you must emphasize that there is absolutely no evidence of adipose-derived stem cells increasing cancer recurrence.
Extensive clinical studies have shown no increased recurrence rates after lipomodeling compared to matched controls.
Okay, final segment. Nipple areola complex, or NAC, reconstruction. Reconstruction isn't complete without the NAC. What is the ideal timing?
Most reconstructive surgeons prefer to delay NAC reconstruction for a minimum of 3 to 6 months following the definitive breast mound creation.
This mandatory waiting period allows the flap or the implant to settle into its final anatomical position under the forces of gravity.
If you reconstruct the nipple too early, as the breast mound descends, the nipple will end up pointing towards the ceiling.
Waiting allows the patient to stand in front of a mirror and mark their preferred symmetrical position accurately. So what are the techniques for nipple recreation?
You start with the simplest, an external custom-made silicone prosthesis attached with medical adhesive.
Non-invasive, but requires daily maintenance and risks falling off during physical activity.
Surgically, nipple sharing is an elegant option. You harvest a composite graft, taking the tip of the contralateral native nipple, assuming it has sufficient projection to spare, and graft it directly onto the reconstructed mound.
But the local flaps are the ones you will be asked to draw or describe.
Let's start with the skate flap, originally described by Little. It's named because the design resembles a skatefish.
You elevate a central core of dermis and fat and wrap it with the lateral dermal wings.
The critical detail is that elevating those wings leaves a completely de-epithelialized donor site around the base of the new nipple,
Mandating the application of a full-thickness skin graft to cover the defect and simultaneously recreate the areola.
The star flap addresses that specific drawback of the skate flap. It's a modification where the geometric design of the surrounding tissue allows for primary direct closure of the lateral donor sites.
By closing the donor site directly, you completely avoid the need for a skin graft, significantly simplifying the postoperative care.
You then recreate the areola later simply by intradermal tattooing.
You also need to know the tripod flap, which uses 3 triangular flaps drawn up to a central point like propeller blades.
However, the tripod flap is notorious for a high risk of severe postoperative nipple retraction, flattening out over time due to the lack of central bulk.
Other variations include the CV flap and the double opposing tab, or DOT flap.
The universal enemy of all local skin flaps for nipple reconstruction is the loss of projection over time due to scar contracture and the pressure of a bra.
To combat this, what role do cartilage grafts play?
You can theoretically use a carved block of cartilage as the sole method of reconstruction, placing it in a tight subcutaneous pocket.
But it feels unnaturally rigid to the touch, and there's a very high risk of the sharp cartilage edges extruding through the thin skin, particularly in irradiated fields.
The much more common testable application is using a small pillar of cartilage as a central strut or core, wrapping it inside one of the local skin flaps we just discussed,
providing an internal skeleton to maintain long-term projection.
The source of that cartilage is generally autologous costal cartilage.
You often harvest a small segment of rib cartilage during the exposure of the internal mammary artery and vein, which serve as your recipient vessels.
You can bank that spare cartilage in a small subcutaneous pocket in the inframammary fold during the primary surgery, retrieving it months later for the nipple reconstruction.
And if autologous cartilage isn't available, irradiated allograft rib cartilage from a tissue bank is a perfectly acceptable alternative.
Finally, how is the areola reconstructed?
Tattooing is the most common approach, performed either simultaneously with the nipple reconstruction or in a delayed fashion once the nipple flap is healed.
The examiner will want you to note that medical tattoos inevitably fade over time due to macrophage clearance of the pigment, requiring touch-up sessions.
The alternative is a full-thickness skin graft.
You can harvest this from the peripheral margin of the contralateral areola during a symmetrization mastopexy, ensuring a perfect color match.
Alternatively, you can harvest non-hairy pigmented skin from the area lateral to the labia majora.
As the natural hyperpigmentation in the groin closely mimics the shade of the native areola.
We have covered an immense volume of material today. Let's summarize the key takeaways.
Mastering Clough's oncoplastic classifications, understanding the intricate vascular pedicles of the workhorse flaps, and memorizing the exact anatomical branching of the DIEA are non-negotiable for passing your board exams.
You must articulate the physiological difference between Holmes and Hartranft's perfusion zones.
And you must know the precise indications and complication rates for integrating a cellular dermal matrix into your implant algorithms.
It's entirely about understanding the reconstructive ladder and selecting the right tool to overcome the patient's specific anatomical limitations.
Exactly.
I want to leave you with a final provocative thought to analyze as you study.
Think about the future of our specialty.
Given the rapid rise of highly specific, minimally morbid perforator flaps, like the new DFP, combined with the proven, undeniable neovascularization and contouring benefits of massive volume lipomodeling,
Challenge yourself to think about whether implant-based reconstruction will eventually become completely obsolete for non-irradiated patients, replaced entirely by precision autologous tissue transfers.
Or will the sheer surgical efficiency, the lack of donor site morbidity, and the drastically reduced operative times always keep alloplastic devices firmly entrenched in the reconstructive algorithm?
Think deeply about how you would defend either of those positions to a senior examiner.
That brings us to the end of this revision deep dive. Thank you for joining us. Don't forget to hit follow so you never miss a deep dive.
And subscribe to the premium feed right now to master your clinical cases.